Welcome to Blunt Dissection, the podcast where we take clinical topics and cut through the noise to what actually matters for GPs. I'm Tom Gillham, a practising GP and Associate Medical Director for Primary Care at East and North Hertfordshire, teaching NHS Trust. Each month, I sit down with a clinical colleague from the Trust to unpack the issues that land in primary care, often at the worst possible moment, and work through what to do next. Practical, honest, and to the point. This is Blunt Dissection. Hello and welcome. One of the commonest things we do in primary care is request blood tests. But interpreting thyroid, parathyroid, endocrine results, particularly those which are borderline or mildly abnormal, is often where some uncertainty begins. We're not always sure exactly what to do. Certainly I'm not. Today I'm delighted to be joined by consultant chemical pathologist Dr. Adie Viljoen, who's giving up time today to take us through an explanation of thyroid function tests, talking a bit about reference ranges, and also touching on calcium and parathyroid hormone results. Adie, thank you for joining us.
Tom, thanks very much for having me. And so I am involved with looking at a lot of results that are requested by your colleagues, primary care. Mm-hmm. These results come through to us, and we have tried to provide some interpretation, some comments on this. So I'm hoping to give you a little bit of advice on this, like what reference intervals actually mean. Sure. I think this is all common knowledge, really. So people know this, but it's kind of a reminder what it means. So probably just dive in as reference intervals are set up of what we call normal. But as you can think, if you dive deeper into these things, what really is normal? So we take a population, we say they're normal. But of course, and then we have got this 95% confidence interval Gaussian distribution. And if it's 95%, we would say 1 out of 20 results would be abnormal in somebody that is already normal. So of course, if a result lies slightly out of normal, it could still be normal. And I think we all know this, but we sometimes forget that. We just focus on the results red, and it's outside normal, and that's going to be abnormal necessarily. And of course, we do a test by first having a question. What's my question? Why do I want to do this test? Is my patient tired? What are the symptoms? And it starts with the things that we learned in medical school. Start with a history, clinical examination, and then you go do appropriate testing. You're going to do lots of tests. You're going to end up with some slightly abnormal results, which may be quite difficult then to interpret and to handle on from there.
Yeah. And I think we as GPs see these abnormal results, these red things that flag up from ICE, and my immediate inclination to try and sort that out. And actually we're going to touch on the fact that sometimes maybe just repeating the test, or there are other reasons why this might be abnormal, even though the patient's really well. Okay, so before we go into individual tests specifically, you've obviously spent many years looking at endocrine blood tests. What is the biggest misunderstanding you see among clinicians, GPs, when interpreting endocrine investigations? What sort of things are you seeing?
So I think, again, as I said, I think you get slightly abnormal results, and then you just fly off, and this is abnormal. I think within endocrine, I think it's good to remind ourselves of the axis and how the pituitary function works, or the axis of, if we think of thyroid function, so you've got pituitary secretion of TSH, and then you've got thyroid hormone. So we the most important test that we do is TSH. And that's probably my first take-home message when we think of thyroid function testing. Look at the TSH. For a number of reasons. The TSH is a robust assay. So of course, this is all done analytically by instruments. T4 is measured in very low quantities. It's free T4 and picomoles, very low, and that can vary quite easily with things like drugs, etc. So TSH is robust, and it tells us most what's going on. As a reminder, the brain is in charge, and the TSH is secreted by the pituitary. So that tells us most often what is going on with thyroid function when the patient's on thyroxine, or whether you're just investigating someone who's maybe tired or has palpitations or diarrhea when you think of hyperthyroidism.
And you produced some, or you sent me some interesting diagrams, which I've been poring over trying to interpret. They should be available on the YouTube version of our podcast. We have got some here. So you talked about the axis diagram. We've got an interesting graph here, and I didn't realize that TSH was on a logarithmic scale. So in fact, minute changes, I think, in T4 can cause huge variations in TSH, right?
Exactly. Again, so physiologically and analytically, TSH is robust and important. So what it means is, if the T4 changes about twice, twofold, so if you have a doubling or a halving,
from 5 to 10 or something
5
like
to
that.
10, or from 10 to 20, what will happen to TSH? It's an inverse logarithmic change in TSH. So in other words, more than a twofold change will lead to 100, more than 100-fold change in TSH. So if your T4 would double, your TSH would come down by more than 100-fold. So orders of magnitude. So that tells us the brain is extremely sensitive at sensing the amount of T4 that is in circulation.
Yeah.
And that's why TSH is going to tell you the story.
Okay.
That is why, maybe you want to talk about it later, but that is why we see things like subclinical hypothyroidism. So what is that?
Yeah.
That's when the TSH is slightly high,
Yeah.
out of the normal range.
Yeah.
So say now 6, 7, 8, maybe 12. The T4 is still normal because the brain is very sensitive at sensing the amount of T4. The TSH already responds very quickly, and then you see this, and I suppose you see that quite commonly.
Yeah.
You investigate, someone's tired, you see, oh, the T4 is now 12 or it's 8. Sorry, the TSH is slightly high.
Yep.
And so it's like 12 or something like that, but the T4 is still normal.
Yes.
So that's what we call subclinical hypothyroidism, which is far more common than subclinical hyperthyroidism.
Yeah, we see a lot more of that in GP, certainly. So I was going to go through some scenarios to try and give us some context and make it relevant to GPs. If I saw, for instance, I don't know, a 58-year-old that's come in, she's a bit tired, TSH is around 5.8, free T4 is normal, so slight raise in TSH, all the other bloods are normal. She's otherwise well. What do we do with that? What do we do with that?
I think again is the context, if they're otherwise well. So we've got nice guidelines on this, and they recommend that you can. So firstly, you want to, again, this is kind of a take-home message in terms of blood tests. Check the trend, check the patient. I mean, most tests are done actually as monitoring tests. So we wouldn't just make a decision, as you know, on a single result. We check a cholesterol, we treat a patient, we check a cholesterol, just like a blood pressure, a lot of things, HbA1c. These are all monitoring tests, creatinine, kidney function. We look at trends all the time. So I think that's kind of intuitive. We do that all the time, but sometimes we forget that. So again, if you have the scenario, I would repeat it, recheck it. If it stays
in a few months,
three, and again, this is how long is a piece of string? How busy are you? What can you do? Except your own constraints. In the ideal world, you maybe check it more sooner, but I think 3 months is certainly reasonable. 6 weeks to 3 months time, recheck it, see what happens. Look at the trend. But there are other things that can influence TSH. For example, if your patient's unwell, euthyroid 6 syndrome, probably we see less in primary care when your patient's actually well, generally well, but they could have a UTI or something else.
So UTI or a chest infection, that could knock off your TSH?
Totally, can interfere with the TSH and will be abnormal. And that's why we often, in the hospital setting, we say, you can't really interpret if the CRP is really very high. It's very hard to interpret, so you need to be actually well to look at thyroid function tests.
Because we'll often see a patient that's not well, that's why they come to see us, and then we'll rattle off, a battery of tests, an FBC, a U&E, an HbA1c, a lipid profile, a TFT, and they might be unwell because they have some underlying infection or some disease process going on, which will then affect the TSH.
Of course.
So, of course, you have to interpret that
in that context.
In the context of the patient's presenting symptoms.
Exactly. Yeah. And you can do a CRP as an add-on. We don't want to do a necessary test, but if you want to make sure if the CRP is normal, you can reassure yourself that you don't have something like euthyroid 6 syndrome that's going to interfere with the TSH. So that's probably the most important thing. But if it stays consistently high, and we do see it, because TSH is so sensitive a marker, if it's above 10, current nice guidelines say you can treat your patient with a low dose of thyroxine, like 25 micrograms. You can start treating your patient. You don't want to go too, you have to be careful if patients have arrhythmias and things like that. You don't want to over-treat them because you don't need to go too far. But often patients may feel better. Sometimes the symptoms, as you know, are subtle. People are tired, depressed, down.
There could be other reasons for the symptoms.
So many reasons.
I mean, can you get symptomatic from a borderline TSH? If it's 6, 7, is that going to be enough to cause symptoms?
It's hard to tell. People use this cut point of 10. It's just a nice number, and they say actually above that you can treat. We know, for example, some things are related to more side effects. On a different thing that I do is treating people with statins, and statin intolerance is related to hypothyroidism, which we sometimes forget.
Yeah.
So sometimes these people I would tend to treat them a bit and just normalize their TSH. And of course, in other conditions which are far more specialist, like pregnancy, we definitely want normal thyroid TSH, in fact, in the lower end of the reference interval.
Yeah, okay. All right, so another very common scenario for you, Adie. A patient's TSH is totally suppressed. The free T4 is within the reference range, so very low TSH, 0.01, whatever, normal T4. Does that automatically mean hyperthyroidism, or could be something else going on? Exactly.
Again, you can have the subclinical hyperthyroidism because the TSH is so sensitive. Again, it's already going down, but the T4 is still normal.
Yeah.
Sometimes we get it's a rare condition, T3 thyroid toxicosis. So it's helpful to do a T3. Sometimes the laboratory helps and adds on a T3, but it's kind of rare. Another thing to think about is drugs. Drugs can influence thyroid function all the time. So if you want interpretation of your thyroid function test, it's helpful to say which medications the patient is on. So most common drugs that suppress or get TSH down are called glucocorticoids, so corticosteroids, and they would have them down as well. And again, you want to monitor this. And the other thing to do in terms of thyroid function follow-up is do thyroid peroxidase antibody testing, so TPO antibodies, to see if the patient is more prone to autoimmune disease. They will then go on becoming hyperthyroid, so that to do the antibody testing when you do your follow-up test.
Okay, cool. What is the most common mistake you see when interpreting thyroid function tests? So what are GP colleagues, what are we doing when we're interpreting these tests sometimes, or what sort of advice and guidance requests are you getting which you think actually, if they'd just done X, Y, Z, they didn't need to ask that question? Is there anything that you can...
I think if you want interpretation is certainly to look at the drugs the patient is on.
Yep.
So that's one thing. And again, you may see borderline lower T4s, and I think you mentioned you may see that. So there has been a shift in the platform which has been measuring thyroid function.
Yeah, we've gone to that HSL provider
exactly.
the last year or so.
So the companies, there's a bit of background, the companies that perform these assays is kind of an oligopoly. There are not many of them. There's Siemens, Roche, Abbott, etc. So where your blood test, your patient's blood tests were done at Cambridge, they use Siemens platform. Now we use Roche platform, and they of course have antibodies directed against these hormones, and their antibodies are patented, and so they are slightly different, and that's why the reference intervals will be slightly different. So if you were to follow up your patient most likely last year to now, you would see maybe slight changes in reference intervals and in monitoring your patient, but they will be small, and they'll be 1 to 2 picomolar. But at the borderline, like 10, T4 of around 10 could be now 9, and you'd say, oh gosh, it's low. So I think just again, I think the most common error I would say is look at the trends, look at the patient, don't overinterpret a slightly abnormal or a lower T4, and T4 in particular. Look at the TSH, and that's probably my main take-home message. Look at TSH.
Yeah, okay, that's good. So I think the temptation is to interpret that as saying, wow, we've got a sudden epidemic of hypothyroidism, but we haven't. It might be something to do with those reference ranges with the new supplier, the new laboratory.
Yes,
potentially.
Exactly. Yes, and
again,
and their reference interval is possibly slightly a little bit higher, and then your follow-up looks like it's out, but it's actually not. I think it's tricky for yourselves, because at the end you have these abnormal results, but I think again the guidance is other. If you're thinking of hypopituitarism, does my patient have a prolactinoma? You will look at other some obvious things, headache, bitemporal hemianopia, things like that will obviously be weight loss, things like that will come in, or other symptoms of pituitary dysfunction, erectile dysfunction in men. Ovarian failure in women. So those are things that you obviously have to think of. And then you have to think, if you do think of hyperpituitarism, it's important to check the 9 a.m. cortisol. That's an important thing. So you expect cortisol to be high in the morning, and that's quite an easy test to do. And that if the cortisol is normal at 9 a.m., then you're also quite in the clear, and we'll check the prolactin. If you are certainly concerned clinically of hyperpituitarism, check the prolactin, check LH, FSH, testosterone, estradiol, and cortisol.
And cortisol 9 a.m. Random cortisol is no use at
Random
all.
cortisol, because cortisol fluctuates. In the evening it's low, so when we need to get up in the morning, the cortisol needs to be high.
Yeah. Okay. Excellent. Brilliant. Okay, we talked a bit about reference ranges, and we talked a bit about, a lot about thyroid function. I had another dilemma for you, a sort of scenario. We've done a fairly comprehensive panel of bloods on a patient, okay? You talked about how 1 in 20 results will be abnormal, but in fact that's just one of those things. And we talked, and you showed us a diagram again, which is interesting. So in this patient, I do 20 blood test results, and one comes back just outside the reference range.
What do we do?
What do I do with that?
Exactly. I think, again, trends. I think we've kind of emphasized this. And I think a lot of people know this, but we sometimes forget it, especially if you do many tests, you're faced with this and one abnormal result. You want to interpret all of this in the clinical context, as we were taught, not just to do blood tests, tick a lot of boxes, because then I think you will be faced with slightly abnormal tests. I think the other thing about reference intervals is some of them have got this nice bell-shaped curve, a beautiful bell, with 95% confidence of 95% of the population lying within this bell. But actually a lot of tests are skewed to what we say to the right. For example, liver function tests, like ALT, and I think you probably commonly see some ALTs.
We're seeing lots of raised ALTs.
ALT slightly on the higher end, and you're like, what to do? And we know the most, currently, in the world we live in, is fatty liver. So as the common term, but is now called MASH, or non-alcoholic, traditionally fatty liver, steatohepatitis. So that will skew your ALT a little bit to the right. And so again, who's normal? If we go down and measure normal people and we just select them and we say you're on medications, you're feeling generally well, we'll see that ALTs actually go up to like 60, etc. So bringing that to kind of a lower level of an ALT of say now 40, you may kind of you don't want to miss people with liver problems, but again, you want to look at the trends, look at medications, etc. And probably my one message is the common things occur commonly. It's going to be fatty liver. It's not going to be Wilson's disease, and you don't need to check a ceruloplasmin or alpha-1 antitrypsin deficiency, etc. But I think if it's consistently, and you look at trends, if it starts doubling or going up, then you want to start investigating further and do your ultrasound scan and look at, can you identify fatty liver, make a more formal diagnosis.
Okay, so if we picked up an ALT of 60 or so in a middle-aged man who's carrying a bit of extra weight,
then you
wouldn't
would
necessarily
expect
get too excited.
No.
I'm sure mine's slightly high. Don't comment, yours is fine. We'd repeat that maybe in 3 to 6 months, and as long as the level is fairly static, I think we worry about missing some liver disease.
Exactly.
Certainly I would do in primary care, so we want to get the scan done urgently, but maybe we just sit on that for a bit.
Just follow up. Follow it up.
Test.
And of course, if someone has a slightly high BMI, you're going to expect, you would actually be quite surprised if you have a normal ALT in this patient. So I think, and that's again the trend. So in terms of liver function and the other liver function tests you can add and look at that, but you will get maybe slightly higher gamma GT, even with fatty liver. And obviously look at alcohol. It's not always easy to kind of know, people don't always tell us that, but these are the other additional investigation you would do. But probably my other take-home message, you don't have to rush off and look for Wilson's or alpha-1 antitrypsin. I mean, you can go and do viral studies. And again, maybe on statins, I think a lot of people are afraid they start a patient on a statin and then and the ALT is like 60 at follow-up. So generally BNF recommends 3 times the upper limit of the patient's normal. So you would start getting concerned. So we're thinking 150, that kind of level you want to discontinue, stop and start. But again, like thyroid function tests, is why we're on liver. Again, a virus, classically we saw in COVID times, virus is going to get your ALT up, and then that's why you want to monitor it, because it will very often normalize after an infection, etc. And these things can be quite subtle, we don't always know, and then the liver function just normalizes. So again, looking at the trends again. Okay,
and before we move on to the calcium parathyroid stuff we're planning to talk about, back to hyperthyroidism. Again, GPs, I get very nervous about starting carbimazole in some of these patients. Tell us a safe way to manage a patient that's got a seriously suppressed TSH and a raised T4 How would you manage that?
So this, you can have a condition called transient thyroiditis. So you can see this picture. So again, monitoring and follow up and look at the patient, and obviously you don't want to miss any arrhythmias, etc. If patient is a cardiac patient. And I think when it's slightly high and to start carbimazole, depends on your own expertise and understanding of these conditions. I would, if you're not certain, I would go then. Therefore, I think in the endocrine department's excellent. They'll give you good advice and guidance for this.
So it's reasonable to see that, not start carbimazole, do some advice and guidance. You'd get that back to us quite quickly.
Yes,
that advice.
Yes.
We might start on 5 milligrams or something and titrate up, or you'd be taking over the management of that patient quite quickly.
Quite quickly. I think that'll happen quite quickly, and I think in that context, advice and guidance and actually help, starting carbimazole and monitoring is important. Just one thing about thyroid function test and follow up. Yeah. If you've had a low TSH for a long time, so if you start a patient, for example, on carbimazole, just to remember, the pituitary is now kind of switched off. The T4 has been very high. We're talking hyperthyroidism. People always go hyper over
30,
so
40.
T4 has been high. TSH is kind of switch off. It takes a very long while for the pituitaries to start responding again. So you could, once the TSH been suppressed or low for a long time, it stays low even though the patient's T4 can start normalizing, because it's kind of the factory has been switched off. It's not making any TSH.
So you start carbimazole, TSH stays very low, T4 starts coming down, but you're not seeing any TSH change.
And therefore you have to be quite careful in those patients, because if you start up titrating the carbimazole dose, all of a sudden it can flip and the patient can become hypothyroid quite quickly. So they need close monitoring. Yeah. One thing about monitoring thyroid function tests generally is the T4 has a very long half-life. It's got a half-life of a week. So steady state is 5 weeks. That's why if your patient's on 100 micrograms of thyroxine and they just on this thyroxine and they're quite steady and they're taking it, it's not going to be interfering the TSH. And that's, again, look at the TSH, because the TSH is showing the steady state, what's going on. If the patient had to have a blood test, and they take their thyroxine in the morning or the blood test, and they're absorbing their thyroxine, it can lead to about 10-20% increase in T4. So a T4 can again be misinterpreted, but look at the TSH again. And again, the TSH, as you said, for hyper and carbimazole can remain low for a long while before it starts responding. And those people do need close monitoring with carbimazole, and it's sometimes subtle and it's different because people are different. We tend to give these doses more in children per kilogram doses, but very often in individuals we tend to dose them not always per kilogram, and obviously people are different. And another thing to think about in terms of carbimazole or thyroxine replacement is absorption. Is my patient actually absorbing what they're taking? Do they have it on an empty stomach? Can something influence absorption?
Like PPIs can affect
PPIs, iron,
metformin, or some of those diabetic drugs, perhaps.
Exactly. Or in patients with diabetes and there's delayed gastric emptying, all these medications that lead to the Manjaros and the tirzepatide, semaglutide, delayed gastric emptying can influence the absorption of the thyroxine.
Is Manjaro affecting the absorption of thyroxine too?
There's delayed gastric emptying, and the thyroxine is absorbed in the small bowel. So if you have delayed gastric emptying, in particular the oral semaglutide Rybelsus, that needs to be taken in an empty stomach as well, and that obviously interferes with thyroxine absorption. So there we say take your thyroxine at night time. Medicine is so complicated.
It is.
And biology is tricky, and especially if people are on medications. I've already said that for thyroid, lithium, carbamazepine, inducers of liver enzymes, these can all interfere. I already said glucocorticoids put the TSH down. So these things can all influence thyroid function.
So if they're on treatment for polymyalgia or something like that, that can knock your TSH down? Okay, all very relevant. We could talk about this stuff for hours, couldn't we? There's so much to cover. I'm sorry we're trying to compress it into a short podcast. We are going to touch on calcium and parathyroid hormone. These results often generate referrals or requests for advice and guidance. They're not always straightforward to interpret. Where do we begin with PTH? Tell us about.
So when you ask what should we talk about, I do see a lot of results that are parathyroid in just individual PTH levels that are requested. Maybe it's advice and guidance, but we struggle to provide interpretation for yourselves on that. So when you do PTH, think of the axis. You need a calcium. It's really hard to interpret. So usually a patient
again,
is...
You showed us that lovely diagram you got, Adie. We'll show that on the video as well.
And that's the axis.
It's great. It's like being back at medical school again. I recognise this diagram, which is reassuring. Okay. Yeah, but talk us through it.
Yeah, so the PDH, the parathyroid gland, senses the amount of free calcium. And then if the calcium is obviously high, PDH goes down. So it's this whole inverse thing. So, and that's where we often investigate people with hypercalcemia. You may have a patient with classical moans, stones, bones and groans, hypercalcemia. And then you would you pick up hypercalcemia, then you need to do a parathyroid hormone test.
Yeah.
If it's high, then you're kind of thinking hyperparathyroidism. The parathyroid hormone could still be in the normal range if the calcium is high, and that could also still be primary hyperparathyroidism, because you'd expect the PDH to come down if the calcium's high. Hey?
Yes.
So then we're thinking primary hyperparathyroidism, and if you don't see a high PDH, you see a really low PDH, you actually think of things like malignancies. So that's the quick take of calcium, high calcium, and low calcium, you want to check a PDH again.
Yeah.
So low calcium, it's the most common reason for a low calcium is post-surgery, parathyroidectomy. So that's what we see. But there are other conditions that can lead to that. But the other take-home message is vitamin D. So high PDH again is very sensitive. If vitamin D is low, your PDH will start climbing up. So that's actually quite a sensitive test of vitamin D deficiency. So check vitamin D. So I think maybe if you want to interpret calcium and PDH, you need to check vitamin D, you need to check calcium, you need to check PTH. And also good to check magnesium, because a low magnesium can lead to a low PDH as well. So we want to, if you have a low PDH, we can't really always interpret it. And the other last thing is renal function. The kidneys excrete, so you'll classically see people that have CKD, have higher PDHs because it's renally excreted. And so if we see high PDHs, we don't know what the renal function is. We don't know what the vitamin D is. We can't, and it's hard to interpret. So again, it's influenced by so many things. Most importantly by calcium, but other things like magnesium can influence it. And then alkaline phosphatase and hyperparathyroidism can be useful as well, because there's more bone turnover. So an alkaline phosphatase will help you a little bit. And the phosphate will be low because it's phosphate-uric if you have hyperparathyroidism. So you really want to check all these things. PDH, you want to look at calcium, you want to look at phosphate, you want to look at vitamin D, you want to look at renal function, and you want to look at magnesium. So please do, I mean, we don't want to say don't investigate. We don't want to do unnecessarily too many tests, but in this context, it's useful to do all those investigations.
Okay. So just going back to two simple scenarios that we would see in primary care. I don't request PTH nearly as often as a TFT, but a patient's corrected calcium is 2.74, slightly elevated. The PTH comes back normal. And you mentioned this could be
hyperparathyroidism.
Okay.
Because in the hyperparathyroidism, so again, because the parathyroid sense the calcium, there's a lot of calcium it's sensing. It's saying there's enough calcium and I don't need to secrete PDH. So you'd expect the PDH to come really down, quite low, if the calcium is 2.7. 2.7 is already quite high. And within the reference interval, if it's like on the higher end, you're thinking hyperparathyroidism. And again, common things, commonly it's more common in females, far more common. So think about the patient in the context again. When we circle back to this whole idea, it's all to be seen in context of where the patient, what patient's in front of you, who you're doing the test for, etc., which will aid your interpretation.
Okay, so another scenario for you. This patient has got a slightly low calcium, elevated PTH, vitamin D levels around 18. Most likely explanation?
Yeah, that's vitamin D deficiency. And there you want to replace the patient's vitamin D. There's good guidance on that. So we can replace the patient's vitamin D before you would say the patient is hyperparathyroid. Because that's a kind of an appropriate response. Of course, vitamin D is part of calcium metabolism.
So secondary hyperparathyroidism because of vitamin D deficiency.
Exactly.
I'm learning something today.
Exactly.
I'm learning.
Exactly.
I can't wait for my next PTA.
But there you also want to go and check normal renal function, because it can look like this in a patient with CKD, of course, as well.
Okay. Good. We're almost there. It's been a really interesting episode. There's so much here that I want to talk to you more about, but obviously we're constrained by time. Quick fire round for you. A couple of minutes, okay? So I'm going to give you a sentence. You're going to complete my sentence for me. Okay. Number one. The thyroid result I see overtreated most often is...
probably investigated most often is, I think, possibly a low T4, where the T4 is overinterpreted and people are not looking at the TSH.
Got it.
Look at the TSH.
Mildly raised TSH usually means?
Well, most often subclinical hypothyroidism.
And repeat the test in 3 to 4 months.
Repeat the test 3 to 4 months, but remember, euthyroid sick and other scenarios.
Check for drugs, all that other stuff we talked about. Biggest misunderstanding about reference ranges?
Well, an abnormal result doesn't mean the patient's necessarily abnormal, and obviously subtle. If it's barn door, it's always easier, and that's the difficulty of medicine. When it's far out, then we know.
Yeah.
If it's subtle, it's probably just subtle.
Okay. One blood test that should never be interpreted on its own?
Well, PDH.
PDH, got it. First thing I should look at on a thyroid profile?
TSH.
TSH, with that logarithmic scale, which you're all going to learn about when we show you those diagrams. One investigation that I should add to an elevated PTH?
Calcium.
Yeah. One endocrine referral that could be avoided if we did things a bit differently. Are there things you're seeing lots of that you think, if the GP just could do that? And I don't want to ask too much of GP colleagues, but is there something quite straightforward you're getting lots of, which you think we might be able to intervene with?
So again, I think you want to have a more thorough investigation of thyroid with the drugs and understand it before you necessarily regard this as an abnormal test, whether it be PDH. Do all those tests, the workup is relatively simple, I would think, and also with thyroid function, and look at the trends. Yeah. If there's no big change, and it's kind of obvious, but sometimes we forget that.
Okay. And the one thing you'd like every GP to remember from this episode? There's quite a few bits, but is there anything you think, just remember that one thing?
One thing, I think, look at the trends, report things, view it in context.
Yep.
Make sure you had a good question to start out with. What was your question when you actually embarked on doing this test?
Yep.
And also remember that a lot of the things I think you may be faced with is you'll have people that are tired, it may be mental health, they don't sleep well, hair falls out. These all things come with a lot of endocrine investigations, but unfortunately a lot of them don't always provide us the answer. And I think it's reassuring if the investigations come back normal. But for example, if you are tired and you have a slightly abnormal result now, you have to start dealing with it because you've got an abnormal result, and that may not be the cause of the initial symptoms of the patient. So I think it still remains quite tricky, but I think coming back, look at the trends, look at the patient.
And sometimes
think of drugs.
We as GPs might want to put the hook on that abnormal result, and the patient wants to as well. And perhaps we're colluding with them knowing that's not really the cause of their symptoms, but we found something a bit abnormal, which we then say, that's what's causing your symptoms.
I think vitamin D is a classic there.
Yeah. Excellent. Listen, that's been absolutely fascinating. Brilliant whistle-stop tour of lots of endocrine stuff. Thank you for joining us.
Thank you, Tom.
We will do another episode at some point, so big thanks to Adie Viljoen, and we will see you next time around.
Thank you.